Okay,
Yeah.
Don gives me a thumbs up. Excellent. Welcome, everyone. As I was just mentioning, we have today with us Terry, who is producing and taking over from John, since John is traveling and is currently in Arizona. We have Karen with us from Wisconsin, and she's also co-hosting with us today. Today is our not sad, happy, somewhat finale to this series being a weekly town hall. Terry and I are working on a new project. We're going to be expanding the topics that we cover. It will no longer just be focused on weekly COVID news, but it's important that we continue to provide COVID-based information and try to make sure that the dissemination of good public health information that can protect you and your families continues to get vetted by us, get curated, and presented in a way that you've been used to for the last 6 months. So this is our 24th town hall. I'd like to thank Terry for being with me every single week, and Karen for joining as our co-host for the last, I think, almost 4 months or more. John, even though he's not here, I'd like to thank him for producing this and publicizing it, and actually making us a presence in on Facebook and elsewhere, where we've gotten a lot of positive feedback about the information we've been able to present and how it's been useful and helpful to many. Um, Recently, I posted that I've been overwhelmed with messages, both through the FB Messenger and just in general. I can't keep up at this point. Terry and I were just discussing, I do feel bad that I'm not able to personally respond to all the messages and emails. Terry does help me vet them, and if there anything that requires, like, my personal attention, a family member or yourself has gotten ill acutely and needs some advice, or if there's anything else that I can do for you guys, we will do our utmost to make sure that we pay attention to those. But don't feel bad if I don't get back to you. Some of you have my personal email as well. I'm not able to correspond with everybody. Um, so this week we are going to focus on um, obviously the news of the week about certain CDC announcements that have been obviously misconstrued as usual. And we're going to talk about a new Sentinel paper that is actually being reviewed now by clinicians and other biomedical scientists, um, presenting a more detailed picture of what we had been talking about for many months as one of the most detrimental parts of the COVID progression of disease. So as you've heard us talk about cytokine storm, within the cytokine storm, it's been identified that one of the cytokines, which is a signaling molecule called bradykinin, has been identified as something that is of merit to look into as a therapeutic target. So I'll be covering a little bit about that. There's some molecular biology and some horizon, some therapeutics on the horizon that we may be able to discuss. And then we'll conclude with some questions and also revisit Sanjay's plan to end the epidemic, the pandemic, and we'll go step by step to see. We presented this on week 10. I think we developed it on week 8, and then we presented it as a slide on week 10, and now we're week 24. So let's revisit that and see how effective we've been in addressing those recommendations. Okay, so as usual, I pause here before I start up the PowerPoint to take any pressing questions or anything that you want to suggest that I cover today.
Do I have to throw controls back to you?
No, I can share. I can
Okay.
still share.
All right.
Since we are now in the in the previous format, not webinar, you guys can use the chat instead of the Q&A panel. And just go ahead and put your comments and questions in the chat window, and Karen and Terry will curate those for us and stop me as necessary when the questions come in and stop me at an appropriate time so that I can address them for you. Okay?
I'm sorry to say I've tried about 10 different things and Facebook Live is not going. I don't know if it's something to do with the format or that I'm not a very good producer, but
I don't know either, because I tried it on my end too, Terry.
okay.
It says that you need to give me the ability to share screen.
Okay, 1 second. You are now host.
Okay, great. There we go, slideshow. Okay, the finale. Here we are, week 24. I can't believe we've been doing this for 6 months. As usual, this gets posted on YouTube, and it also gets posted on Facebook. The unfortunate technical glitch we're facing is that the Facebook Live is not going active, but Terry's going to keep trying to go live for us. As I mentioned, this week we're going to cover some of the CDC data as to where we are right now, the changing recommendations around asymptomatic testing, the recent news on the cause of death, and I'm going to cover how physicians actually determine cause of death, and some deeper definitions that will help you understand the reporting of COVID deaths. And then obviously we'll talk about mortality data and the very, very good news that we have seen in the last 3 months, where there is a steady and definitive decline in COVID-related mortality. Now that means that much higher number of patients who contract COVID are surviving even the most severe form of the disease. In the United States, COVID-related mortality has dropped by 70%. Back in May, we predicted that by the end of June, mortality would drop by 50%. And that was achieved as a result of the usage of dexamethasone and the physical methods of proning and avoiding ventilation as a first resort when these patients started to have a low oxygen concentrations. So, we've talked about this many, many times. There are a number of advances that clinicians have made in the addressing the treatment of these patients in a hospital setting, and the usage of antivirals, immunomodulators, and anticoagulants, and that has resulted in a very significant drop in mortality. We'll talk about the case fatality rate and the infection fatality rate that has dropped, again, very significantly. It has dropped about 80% in Europe and about 70% here in the United States over the last 3 months. So that's a huge round of applause for my friends and colleagues in the healthcare delivery and biomedical research communities that have been challenged to treat millions of patients in the last 6 months, and have risen to the challenge even when they were at or beyond capacity in their ICUs, in their emergency departments, and in their wards. And many of them have worked nonstop for months without a break. And I just want to commend them for their incredible work. And they are saving lives, and the data is clearly reflecting that. So we'll cover a little bit, like I said, about the Bradykinin Theory, which is a more evolved view of the mechanism of infection and what happens when the virus starts to interfere with the antiviral mechanisms that are normally present in the immune system, and how it's a key driver of COVID pathophysiology. And then it also may be a explanation for long hauler symptomatology. So the derangement in the renin angiotensin axis and the production of bradykinin long-term in these patients may be related to the fatigue, the breathlessness, the very, very slow recovery of some of these patients. And we've seen that you don't have to suffer the more severe form of the disease to actually end up being a long hauler. You can have a moderate course of disease initially and then be left with these symptoms and long-term morbidities and sequelae. So we'll talk a little bit about that. And then what to be aware of in the fall, and what is exactly prolonging the pandemic. And of course that Sanjay's end to the pandemic plan slide. So here we go. So right now we have crossed 6 million cases in the United States. The South continues to be a driver. Terry and I were talking about the Midwest now being the new hotspot. Iowa, Illinois, Wisconsin, even Minnesota has remained hot for quite some time. Michigan, and so these are areas where we've seen the initial outbreak on pandemic occur in the Northeast, and then post Memorial Day, we saw the massive outbreak in the South that actually dwarfed the outbreak in the Northeast. And that's when we began to discover that a mutation had evolved that was increasing the transmissibility. We covered D614G and how it created the ability of the spike protein to be more flexible and sticky at a molecular level, increase the ability of the virus to transmit and infect more efficiently, and that's what caused this massive outbreak in the South. On top of the fact that no one paid attention to the public health guidance and did not physically distance and did not use masks, ubiquitously, et cetera, et cetera. So this is now moving into the Midwest. We have crossed 180,000 deaths in the United States. And to make it very, very starkly clear, these numbers, when you compare them to the rest of the world, are outrageous. So we have 4% of the world's population. We have more than 20% of the world's confirmed cases since the beginning of the pandemic. And the count of these cases is that you're seeing right now is actually just a proxy. We have presented information, and there are papers available on our resource page and resource group that indicate that number of 6 million is a proxy, because there is a 1-to-9 ratio of patients that are confirmed positive versus those who never were tested but survived, may or may not have survived the infection. So how many Americans have actually been infected in the last 8 to 9 months? It's probably 60 billion in the United States. One of the new advisors to the coronavirus task force is a gentleman named Dr. Atlas from Stanford University. He is suggesting that the United States has now, essentially, without using the words completely failed, the United States can no longer effectively mitigate this pandemic in any form, nor can it contain it. So the only thing we can do is avoid further outbreak. And certain, he's using certain biostatistic models to show that, to support his theory that this is just the road to herd immunity, or this is a way to now, we have to formally abandon those strategies of mitigation and containment. No shutdowns like we saw in March and April would be successful at this point, even if we had a massive outbreak, and that the United States should just expect to let this play out until a vaccine is available, and therefore we are by default using the herd immunity strategy. However, we have covered in detail why the herd immunity strategy is a fallacy, and why it will not provide any significant protection or allow for the slowing of the pandemic until 30 to 40% of the population is seropositive for protective antibodies. So that means natively developed as a result of infection and recovery. That would only slow the progress of the pandemic. It would not stop it. The application of a vaccine would stop the pandemic from progressing, and that would require 80% or more of the population to be properly and effectively vaccinated. Does anyone have questions about this?
I do, because
Yeah,
herd immunity is always one of my favorite topics. So we have people who are getting reinfected with new strains. And the short-term immunity that people are estimating is 2 to 3 years. The combination of all makes herd immunity a pipe dream, just a ridiculous pipe dream. It's not going to happen. It's no way, no how. The numbers don't work it. You could get my kid to juggle them all day long. Herd immunity ain't happening until we have a vaccine that could take up some of the slack.
Yeah, I don't think that I honestly don't think that the argument is that herd immunity is a solution. I think that the argument is that herd immunity is the only strategy left for the United States. Do you know what I'm saying, Terry? So,
oh yeah, it's a complete.
So we can't track and trace like the Europeans have done, or South Korea or New Zealand. We can't contain because we don't have the political will to shut down or use a national mandate or hit the reset button on this whole thing because of the effect on our economy. So by default, we are going to follow the Sweden model now, whether we want to or not, whether we understand it to be a fallacy and a defective method of dealing with a pandemic, whether we want to or not, we are now in default the herd immunity model. I think that's the key takeaway from what they're saying.
If you saw what happened in Texas, the numbers were so high, tests couldn't be done, and then all of a sudden the numbers magically went down.
Right. So this
magically.
And this is the second point that I want to stress in this topic when we're dealing with the CDC, is that for months we started this, as you know, Terry, Karen, and John and I started this to fight disinformation. And what we evolved past just fighting disinformation, we started to actually produce curated information. So we would go into the pre-publication papers. I was at my peak, I was reading 25 to 35 papers a week, and then developing these weekly town halls and present sentinel papers and the ones that are evolving the trimodal therapy and blah blah blah. But during that initial phase of fighting disinformation, the reliability of anything coming out of the CDC was highly questioned. Well, many of the detractors and contrarian voices were saying that you can't, these are totally overblown, inflated. They are, and this is important that I set this context before I go to the next slides here. They're overblown numbers. Everybody that, you know, even if they fell off their motorcycle and died, if they tested positive for COVID, they were being, tallied as a COVID death, et cetera, et cetera. So they completely undermined the validity and reliability of anything coming out of the CDC. So they've been doing that for months, but now those same people have latched on to two things. One, and the initial stuff they latched onto was unreliability, data's inflated, it's, et cetera, et cetera. It's not as bad as we think it is. It's a hoax, just to confirm their biases. And then they would cling to, well, even Dr. Fauci and the Surgeon General said you don't have to wear a mask. Well, they said that in early February, when they knew that there would be a potential shortage of N95 masks, and they didn't want anybody hoarding them like we did toilet paper. And latching on to things that just confirm their biases. Now, after months of declaring CDC unreliable and untrustworthy, the CDC released data showing that number one, which we'll discuss, is that only 6% of the death certificates had solely COVID as the cause of death, solely. The other 94% had comorbidities along with COVID as a cause of death. Now they have latched onto that, saying that all of these deaths were due to some other thing other than COVID. Only 6% of these deaths were actually COVID deaths. Not only does that somewhat shock the conscience of people like me and others who have, worked on this for and dealt with patients and dealt with crying families and sick people and getting sick themselves. I don't want to walk down that path with you right now, but it shocks the conscience that they would declare that only 6% of these deaths are actually COVID deaths. Okay. And I'll cover why that's a fallacy too. But in addition, the CDC now is posting a recommendation. I have a picture of the website right here, okay? Posting a recommendation that asymptomatic patients do not need to get tested. So even if you are concerned and that you have been in contact with a confirmed COVID case, the recommendation is if you don't feel sick, then you don't need to get tested. Karen, what's wrong with that recommendation?
Everything, and it goes against everything that every other country is doing, doesn't it?
Yeah, exactly.
And how many days can someone be asymptomatic?
Yeah, they can be asymptomatic for up to between 10 and 14 days. Up to 10 to 14 days. So that's a problem, that you have the government agency in charge of this response. Karen, we've got feedback from you, I think. Anyway, so there we go. Thank you. So that's a problem, and we need to probably understand that this data is now politicized. These recommendations are now politicized, and we tried really hard, all of us, to keep these town halls apolitical. But if this is the quality of these recommendations, if they are not evidence-based. And clearly those of us, who have worked in evidence-based medicine can identify the bias and the intent of this kind of information being pushed to the public. It's dangerous. Okay, so this is a cause of death instruction sheet. So basically, it's telling the medical examiner, coroner, or the physician how to fill out the death certificate. And this is generalized. Each state has their own set of instructions. But, here's what it comes down to. You have a primary cause of death. You have secondary causes of death. As indicated here, okay, this top line is usually what kills the patient. All right. And then every line below it should be the reason the patient progressed to this state. Okay. So if the patient, there was a physician that said, I have type 1 diabetes. If I get attacked by a bear and then, end up in the hospital, and the doctors have trouble controlling my blood glucose while I'm recovering from a bear attack, I don't die because of diabetes. The bear attack could have precipitated something that causes my diabetes to accelerate to a point where I go into a, ketoacidotic, coma, and the rest of my organs start to shut down. But I would have never gotten to that state if I hadn't been attacked by the bear. In this example, the bear is the virus. Okay? So you can't discount that the doctor who got attacked by the bear died of all of the sequelae and complications of being a type 1 diabetic. You can't discount that, obviously, okay? It would be erroneous to put just the bear on this sheet, okay? It would be erroneous. And it's erroneous for many, many, many reasons, because on scale, we want to know how many bear attacks there were. We want to know how many bear attacks there were on type 1 diabetics. We want to know how many bear attacks there were on obese patients. Do you understand where I'm going with this? Okay. We need to know these things because epidemiologically, bear attacks occur in California and Wisconsin and Pennsylvania, and all of these populations are different based on their demographics and the prevalence of comorbidities and all this stuff. So when you're filling out a death certificate, it is important that you fill it out correctly and as with as much detail as possible. Now, when you take all those death certificates together, 183,000 deaths that have COVID on them somewhere, and say, okay, I'm just going to read this top line here. Everything else doesn't matter. That's ridiculous. And to have people take the CDC recommendation, highlight it, and then make it a meme, and then share it millions of times, only does one thing, okay? It minimizes the damage that this disease has done to this country, and it undermines all of our public health efforts going forward. Because that means people will continue to not take it seriously. Millions of people will continue to not take it seriously because they don't know how to effing read a death certificate, or how it's filled out, or why it's filled out this way. Okay? And so it actually doesn't, it's not just these instructions that are required to fill out a death certificate. It requires a degree in medicine. it requires an understanding of the International Classification of Diseases, version 10, the coding of it, okay? Not for the billing side, because that's a whole nother science, for the clinical side. And so this is what, you know, someone with an MD or DO after their name does. And I'm embarrassed that I have to explain it.
Hey, Sanjay.
Yeah.
The one good thing that's come out of this for me is I've got to see the percentage of the population that could talk about another human being, another U.S. citizen, and say, they were only going to live a few more weeks anyhow.
Right.
Or you know, were they going to see the end of the year? You know, and they're talking about, you know, a human being, a fellow American. It's just trash.
Right.
It's complete trash.
So the one more thing I want to cover here is that it does go deeper. Okay, it goes deeper because cause of death is different than the manner of death, and manner of death is different from etiology. All right, so if you really want to know, which I'm sure millions of people don't, they just want to hit share on a meme and feel all proud that they were right. This is all a much ado about nothing. Okay, so on our resource page, gentlemen commented that, you know, if you do 7 grams of cocaine and you only write down that the patient had a heart attack, you are now ignoring the 7 grams of cocaine. Okay, so etiology is also important. Okay, an etiological factor could be a drug overdose. An etiological factor could be exacerbation of asthma, COPD, you know, microangiopathy, microcoagulation. These are the pathological etiologies that resulted in a cardiac arrest, or a stroke, or a pulmonary embolism, or a renal infarct, or, you know, the list goes on and on and on. And it's also important that we realize that etiology is part of designating both manner and cause of death. Okay? And you don't need to know this. No one needs to know this. Okay? We should have faith that our medical professionals know enough to do this well. The only thing that bothers me is that 6% of those death certificates had only COVID on them. You know what that means to me? They weren't filled out correctly. That's the only thing that data means to me. So anyway. All right, so we know that rapid testing is an absolute necessity. We've covered this before. We are now seeing this come online where, you know, these rapid disposable strip-based tests are coming out. Dr. Mike Hansen has a beautiful coverage of this, which I'll be posting later tonight, and where you can get them soon. So we should see these, and we talked about this last week, we should see these starting to show up on our drugstore shelves in the next 6 to 8 weeks, I hope. I mean, I hope. They're about 4 months late, but I hope that these will, not just this one with the, you know, we need the antigen test, okay? So anyway, they're going to be a strip. You either use saliva, or, you know, or use a swab, and then you'll be able to test. Okay, so and we'll cover more about testing when we get to how to end the pandemic. All right, so we have now a Sentinel paper. Now, what is a Sentinel paper? Sentinel paper is something that is a new discovery in a specific disease area. So there were about a dozen Sentinel papers over the course of a 20-year research effort in the understanding of HIV/AIDS. And so far, I think we've seen about 4 in the same period. I'm sorry, in a period of time of only 6 months. So again, that's an incredible achievement. All right, so 12 in 20 years versus 4 in 6 months. Right, that's how fast our capability to assess disease and address it has gotten in the last 2 decades. And that's very impressive. The ability to not only identify the causative agent, sequence the genome of the causative agent, understand the underlying genes, understand what proteins those genes code for, understand what those proteins do in the life cycle of that organism, and then determine what are the downstream effects on the human body of infection. To do that in a 4-month span or a 6-month span, I don't know, it for me is mind-boggling. It's amazing. And like I always compare this to HIV/AIDS because all of the techniques that we have today, from reverse transcriptase PCR, Western blotting, ELISA, all of those were born as a result of addressing HIV. So anyway, so here's the paper: Mechanistic Model and Therapeutic Interventions for COVID involving renin-angiotensin system-mediated bradykinin storm. Kind of a technical title for what it's trying to indicate here is that we've known for a long time that one of the things that shuts down the body in COVID infection is a immune response that is not on par with the infection. Okay, it's just a massive release of what we call cytokines, and I'll show you what cytokines are in the next slide or so. They're chemical signals between the cells of the body and the immune system to sequester certain activities at the cell level. One of many, I mean dozens upon dozens of cytokines is called bradykinin. Okay, bradykinin is also known as tissue kallikrein. It's secreted in acute pain response, like any physical injury. For example, if you hit your finger with a hammer, okay, that initial swelling is a result of the tissue damage that occurs to the pulp of your finger, okay? And squeezing of the muscles and that acute damage that happens to the delicate tissue results in it releasing these tiny little chemicals called cytokines. And those cytokines in that localized area, they call in certain responses. So one is obviously there's the neural pain response, which makes you recoil your finger from the injury, either a hot stove or you hit it with a hammer or a nail or something like that. So you recoil. That's the neurological response. But the neurohormonal or chemical local response is cytokine release, and that tells the body, oh, pain, ouch, swelling, local heat. If you feel an injury, it's always hotter than the area around it, right? That's all due to chemical response in that area of injury. It's not the brain sending something along a nerve to tell it to do that. It's the tissue. So bradykinin is part of that response. All right. So I won't go ahead. Anyone want a 3-hour lesson on angiotensin? I'm game. This is my dad's favorite topic. There's
a couple of good band names there, but I'll stick with cytokine storm.
Exactly. Yeah. No, my dad used to, initially, I didn't have the background to learn this stuff when I was in high school. So he tried to teach me this in high school. I would just nod and smile. And then finally, when I got to med school, I was like, oh, that's what Dad was saying. Anyway, so, but I know plenty of internet medics that that are, you know, ready to explain this to you anytime. Anyway, so here we go. So what are all of these cytokines? Look at them. God damn, there's a lot of them. You know, interleukin 1 through 7, 9, interleukin 15, interleukin 21. They all have specific receptors. They all do very specific things in the cell. On the right here, that's this stuff here. On the right, you have chemokines and other cytokines. Some are, you know, based in the circulating cells, okay, and some are based in the static cells, so the tissue, and they all communicate with each other. All right. I'm not going to get into what they do because it's not important right now. But what bradykinin is, it's a potent endothelium-dependent vasodilator, mild diuretic, which means that in circulating quantities, it will cause the kidneys to remove more water from your bloodstream, and that will you know, decrease your blood pressure. So this causes contraction also of smooth muscle locally in the bronchus and the gut, and increases vascular permeability. That's the key here, vascular permeability. What does that mean? Well, it means that when it's released, you know, this whole host of crazy goes on, and it has effects downstream from the endothelial cells that release it into the blood vessels, okay? And it causes these blood vessels to get smaller but leakier, okay? This is just two things. Smaller and leakier means there's less surface area for the release of oxygen or the uptake of oxygen, less surface area for the removal of carbon dioxide, but more fluid is coming out. You know, those plasma bags that I showed you last week with the serum plasma, you know, it's the yellow pale liquid that in which all your blood cells float. That becomes more able to move out of the blood vessel and into the what we call interstitial space. So what happens there is that all of these inflammatory markers. So we've got an infection. It goes down into your lungs, and it then starts inside of the alveoli, and all this white part of the alveoli is the endothelial cells. They get infected and inflamed by the virus, SARS-CoV-2. And then they start releasing those, our cells, not the virus, our cells start releasing all of these cytokines. And these cytokines then cause damage, more damage than the virus itself. All right, that's key to the understanding. So then we get this filling up of the fluid. This is classical pneumonia because the vessels become more permeable. The vessels become more permeable because the body wants to get white blood cells into the fight. Okay, so they get to a point where, you know, they're allowing more white blood cells to come out of the blood and into the space where the infection is present, so they can fight the virus. But what happens is the virus causes this bradykinin release, which then allows the filling of these delicate spaces with fluid and production of some other chemicals like hyaluronic acid. And it's like trying to breathe through jello. Your lungs not only fill with water, which is pneumonia, the water quickly turns into jello. Okay, so then when you start to throw, you know, high flow, high pressure ventilation through a mechanical ventilator down into this, what happens? Massive damage, massive physical damage. This is why we want to avoid ventilation as much as possible in these COVID patients. Okay, so then next is, well, not next, but part of the whole process is this conversion of various molecular markers of cell signaling. So things that are regulating the blood pressure of the body, things that are regulating the vascular permeability, things that are, you know, this stuff is happening a billion times a minute in the cells throughout your body. and it's happening pretty flawlessly. You throw a wrench in the works, and all of this stuff starts to just kind of fall on top of each other. Okay, all of these reactions and all of these biochemical pathways, we call them derangements to the pathway. So when derangements to the pathway are initiated by a viral infection, you get coagulation. Okay, you get tiny little clots everywhere. And then these long haulers, those clots won't clear for months. It takes months for those tiny, tiny little clots in their muscle and their joints and all throughout their integumentary system, all throughout their organs. It takes months for them to clear. That's why the massive fatigability, massive, breathlessness and malaise, and they just feel like shit. Okay. And this may be a continued response. So even after the virus is gone, the body continues to put up a fight that's deranged in the pathways. All right. So this is a theory now. The Bradykinin theory is that, all of this stuff that gets deranged as a result of the viral infection, it sensitizes these receptors, and it may be sensitizing them long-term, not just short-term during the infection and post-infectious phase. It may be sensitizing them longer-term. And this is causing the arrhythmia and heart failures that we're seeing in patients. It's causing, this hyperpermeability and prolonged hyaluronic acid buildup in the lungs. It may cause because of increased permeability in all of the vessels, all the tiny vessels, you're getting a breakdown or a breakdown of the blood-brain barrier that allows for encephalopathy, continued dizziness, malaise, headache. I talked about COVID fog for weeks, months now. We've talked about one of the symptoms of COVID, both in the early stages, through the infectious stage, post-infection, and now in the long haulers, is COVID fog. Cognitive impairment that is a result of this microvascular derangement. And then
Sanjay?
Yeah.
I hate to interrupt your slide gold there, but I think Karen's in the waiting room.
Oh, jeepers. Admit.
Yeah, she had to reboot.
Okay. David's here. Okay, admit all.
Sorry about that.
Hey guys, sorry. We weren't paying attention to the waiting room. Sorry. So that's basic. Hey David. So that's what's going on with these long haulers, and it looks like this paper has elucidated the actual molecular pathway that is responsible here. Okay. And this is why we call it a sentinel paper. This is the first time the world is being made aware of this research and these the evidence that's come out of this. So this is a collaboration between Yale and it's an international collaboration. So Yale Medical School led it, but this is just outstanding molecular biology research. Okay. As Terry would say, this is Sanjay's jam. This is my thing. Okay, so all of that being said, and having bored you for the last couple of minutes, what do we do with this knowledge? Well, just like with other novel therapeutics for COVID, this brings into focus some drugs that could be used in treatment to address the bradykinin sensitization. So these are already on the market, or what we call orphaned. They've gone through the whole FDA process, and because they only treat a very, very tiny specific disease, they just kind of sit out there and are not very often used. Okay, there's a disease called idiopathic hemangioedema that is very, very rare, for which some of these drugs are used. and it is specifically a B2 bradykinin 2 receptor problem. And this is, you know, beyond your usual average physician. This is something that occurs at the university research level, like maybe 15 physicians in the entire world has ever seen a case of it. But drug development, because we know what receptor needs to be addressed and what pathway is deranged, and so we've gone through the research to develop these. Good news, right? Great news. Okay, so
Yeah, just a question about the drugs you had up. I noticed that oleander isn't on there.
it is not.
I was assured by a pillow seller that there would be a big announcement about that, but
I'm still waiting for it. Hey.
me too.
Yeah. So, you know, maybe you've heard of some of these, danazol, stanozol, and then icatibant is the one that is showing most promise. But, you know, you need to actually understand where in this pathway you're addressing it. I've shown you charts like this for months now, where you're like, okay, we want to put a drug in here. We want it to do this, right? And that, you know, that's the basis of molecular medicine. We want it to stop this from happening. And if you can stop that from happening, then this won't happen. Okay? So like that, we know that this specific drug acts on this receptor, okay? And because of that, it's going to reduce this, and that's going to stop these effects. It could be useful early. It could be useful during the treatment as an immunomodulator. Again, trimodal therapy. This is one of the candidates for immunomodulation during the acute phase of the disease, and it could be used in the long haulers to help them recover more completely and more quickly. Okay. Do we have any questions?
Yeah, we have a statement from David. Isn't timbedicine the one that might stop men from being more at risk?
What is it, David?
Timbedicine?
One that targets the TMS B4X pathway. I believe is the one that is carried. There's some gene that's carried on the X chromosome that makes women less vulnerable to this bradykinin storm.
Awesome, man. I did not know that. Okay. Thank you for that contribution. I will. I think.
Don't quote me on that, but I was reading about this earlier.
Is this from the article that you saw on Medium?
Yes.
Okay, so that's the supercomputer that was
yes.
used. Yes. Okay. So yeah. So your information is good. It's correct.
Awesome.
So yes. So that is remarkable that we're able to use these tools now to find drugs that we actually already have in our arsenal. And that's awesome news. So, and as usual, David chimes in with remarkably good comments. Okay, so I'm going to pause here again and actually go here. Let's stop this share. I'm going to go to gallery. Okay, so yes. Oh, wow, we have lots of good people. We have our this looks good like this. I didn't know if webinar would work. Okay, this looks good. All right, so.
We did have one comment, a question from Jess S. that said, and so in theory, if you're a smoker, would you almost have a better defense than one with healthy lungs?
We talked about this.
Yeah.
We've gotten a bunch of conflicting evidence. One initially and early was that smokers, especially heavier smokers, heavier smokers were not contracting the virus as easily as non-smokers. And this came out of Europe, Spain, France, etc. And we chalked that up to the biophysics of having dirty lungs. So, so basically what it comes down to is the virus couldn't find a grip on a nice clean patch of, ACE2 inhibitors, ACE2 receptors that it could create its own little viral colony and move outwards. And also because it's the damage to the naso and oropharynx that occurs from smoking, that the virus, when it comes to sit in the initial infectious area and cause an initial infection, it's just a big mess. And it's like, forget it. We'll go find someone that.
Well, you know what the upside is, Sanjay?
What?
Munt Yudoshi Industries is coming out with a vape juice. It's maple and coffee flavored with a high dose of nicotine. And we're thinking between that and regular coffee drinking, it could help.
I know, because I was down in the R&D department, and we forgot to tell you about the pineapple and bacon pineapple and ham flavored juice that we're working on for the Canadian market. So
excellent.
What are you going to name this particular flavor? And by the way, my husband smokes, but I'm just going to omit this piece of information from him.
No, and we don't actually know. This is our we haven't done an RCT on this with double blinded, but that's one reason. Okay, now the opposite side of that coin is those that vape actually have a higher transmission rate. Okay, but only because they vape around each other. So they're literally vaping into each other's faces. So, you know what I'm saying, right? Like they're
I don't like people enough to vape with them.
Yeah. So if you're vaping with others, that is going to increase the transmission probability. But that just makes sense. I mean, you're sucking in a huge volume of vapor and then blowing it back out in close proximity to other people. How is that not an awesome way to transmit the virus? Okay. So
David add some extra hydroloric acid to your vape. It creates a satisfying hydrogel.
The hyaluronic acid. I'm going back to that same article. So make sure it gets a nice coating to you. That's what you want.
Exactly.
Yeah, it'll work.
Yeah. Yep. Absolutely. So are we good on questions? And I'll just go to
we are good on questions, but there is a comment here from someone that is basically logged in on their iPad. So I don't know who it is, but this person is saying that their niece contracted COVID and experienced a mild case despite her autoimmune disease. So that's good. She's been taking interleukin 4 and 13 blocker, Dupilam for 1.5 years, as well as an inhaled steroid for asthma.
Yeah.
So good. I'm glad to hear that. Because
Absolutely.
we're always worried about people with the autoimmune disease.
Absolutely. Some of our initial fears about, for example, asthma, COPD, and autoimmune patients being highly vulnerable have not really shown evidence that they are the ones that will suffer the worst. It's actually the hypertensives and the obese patients.
Diabetics have a horrible toll, just an incredibly high toll.
Exactly. So, and we talked about why, and there's a ton of evidence as to the reasons. Is it all comes down to the condition of their micro blood vessels. So in diabetics, their micro blood vessels are very fragile because they have persistent damage from glycosylated blood products, blood agent, And so these are basically at a molecular biophysics level, they keep scarring up their small blood vessels because the damage from these glycosylated products, it's like little tiny razor blades, flowing through their bloodstream, and there's just complete derangement of various neurohormonal axes. So not just blood sugar, but also blood pressure, and also protein regulation, and all this stuff is happening in these diabetics. So you perturb that condition just a little bit with the cytokine, bradykinin, and all these other microcoagulopathies that are part of COVID, and they fall apart. The patients fall apart. and this is true in, there's so much undiagnosed diabetes out there. You can expect that if a person has a BMI over, 30 or 32, they are pre-diabetic, or they're suffering from much of the same effects of a diabetic, because of their, triglyceride level, their low density lipoprotein level, and all this other stuff. So look around you. The United States is a prime, target demographically for this virus to do horrific damage. Anyway, so one more thing to cover, I guess I should have with the CDC information, is that 80% of the deaths in the United States, again, approximate, have been in people over the age of 65. All right. Now, most recently and disturbingly, the average age of the infected in the last 3 months dropped well below 65 and into the 40s. In some states, it dropped into the early 30s. So it was absolutely a behavioral spread. Okay. So the lack of a national strategy, the lack of a national mask mandate, and again, a draconian mask mandate where people are getting tickets for walking around their yard or their neighborhood without a mask on, it's not what we're recommending. That's not the point of this. A mask mandate means in all public spaces where you are going to be within 6 feet of another human being, you need to be wearing a mask. Repeated offenses would result in fines. We're not looking to establish a mask police, and go around in armored personnel carriers and drag people off to re-education camps. Why do they always come up with the most absurd, theory of how we would enforce a mask mandate? That has nothing to do with it.
I'm going to start a rumor tomorrow that the cops are going to be hitting you with a taser if you're not wearing your mask. I think I'll do it on several groups tonight.
Yeah.
Yeah.
So, it's not hard. Here in Pennsylvania, we're pretty much, especially in northeastern Pennsylvania, Chester County and some other of the more populous parts of the state had more struggles. But up here, we are not rural. We are not urban. We are about 15 counties large, and we're fine. And I've been saying this for weeks and months now. I go, and I've been going out since we ended this total lockdown in April, and everyone wears masks. Everyone, even now, still. And we've been in the green for 2 months. Okay, that's how you beat this.
NJ, I'm causing a little bit of a stir in my hometown because there's an article in the paper about a 61-year-old man that had a mask on in an elevator, and a young woman in her 30s tried to get on the elevator with him, and he stopped her and he asked her about her mask, and she still insisted on getting in the elevator with her. He ended up with the disorderly conduct ticket. And I'm asking people why. Why could she, if he was in that elevator first, why could she not wait? Why did she insist on going in an enclosed space with this man? I feel like she was the aggressor. But if you're someone who doesn't believe that this is dangerous, then you don't see her as the aggressor. I feel like she was the one in the wrong, but that's another story.
I've got snoring here, but so I missed that first part. Who was wearing the mask?
A 61-year-old man was wearing a mask.
And she insisted on getting the elevator without the mask.
Correct.
Ah, okay.
And they gave the disorderly conduct ticket to him.
Yeah, that's just stupid.
Because he.
What do you want me to? It's just.
Well, I feel like the police did not recognize that what she was doing was dangerous and aggressive.
It is. It's aggressive.
Yes.
It's absolutely aggressive.
She endangered him, but because he stopped her from getting in the elevator, they gave the ticket. They
Okay.
gave the ticket to him, but she started the chain. Well, anyway, that's my. Don't mess with an organizer, everyone, because I am on this case.
I love it.
I'm
So
organizing people around this. I'm so mad.
why can't people just be nice to each other? Honestly, why can't people? Terry. All right, let's just finish these slides and then we can get into a further conversation here. Oh, all right. So we did this and we did that. And okay, so we've got risk, and we're still the highest risk nation in the world for the development of COVID. Okay. But what we want to get to is safety. We want to have a society where we can play sports, send our kids to school, go shopping. We want to go, we want to have our friends and family over for large gatherings. We're anticipating, the months ahead where Thanksgiving and Diwali and Christmas and all of these, gatherings of humanity occur. I have bad news. You need to do the necessary things to control the pandemic, because you can't just go from risk to safety by snapping your fingers. You can't do it by pretending that it's over when it's not. You can't pretend that people don't require testing. You can't do it by suppressing numbers or twisting biostatistics to suit a narrative that confirms your bias. So, we talked about these 5 things for the country to invest in order to finally bring the pandemic to an end. And so on some of these things, we were marginally successful. On some of these things, we were an abject failure. On, I don't know, on some of these things, we're halfway there. But if we had committed to do these things 4 months ago, we would not be where we are today. So what do I mean by that? If we had diligently assessed the incidence of this disease on the community level by providing, if the National Guard had deployed to a central location in every town with a testing apparatus that allowed for them to do free testing on demand, and that provided rapid results within 24 hours, even if they couldn't do that for the first 6 weeks of the pandemic, even if they couldn't do that for the first 2 or 3 months of the pandemic, the fact that we're still not doing it, and that 80% of our test results, still take about 3 days, and only about 20%, 25% take less than that, is a problem. And so I don't know. Actually, I'm gonna let Karen, David, and Terry. You guys are gonna give on a scale of 1 to 10. Where you guys are gonna, like, you know what I mean? Like, like this is a David Letterman skit. So you guys are gonna give the first line what you think the country's score was on the first line. Terry, you go. On a scale of 1 to 10.
I would give them a 2.
Okay. Karen?
Oh, are you talking about assess incidence?
No, the whole first line. Yeah, the whole first line. What do we get on a scale of 1 to 10?
I live in an urban area, so I'm going to say 5.
Okay. David, on a scale of 1 to 10, how do we do on the first line?
National or local?
You can give him both scores. I would say national.
So national, let's say healthcare access is 0. Rigorous contract
No.
tracing.
You're jumping ahead. I just need the
Yeah.
first line. First line.
Just the first line, access incidents?
Yeah.
Ooh. 1 or a 2?
Okay. So we're averaging to about a 3. Okay. We're averaging about a 3.
And then
So,
I based my score on where I am. I didn't do it nationally.
okay. All right. Then rigorous contact tracing. At the community level, to be able to say that a certain neighborhood is actually the worst affected in a 25-mile radius or a 10-mile radius. And then, strict quarantine of only the positives eventually. So what that means is when you are telling people, oh, well, you know what? You tested positive, so we really need you to stay home for 14 days. And then you do nothing about that. You don't follow up with them. You don't find out whether they're compliant with that quarantine. You just give them that recommendation and allow them to do whatever they want. It doesn't work. Okay?
0 on that one.
Okay. Karen?
1.
Okay. I would give it a 1 also, only because I know that here in Pennsylvania, I'm saying 1. There was some basic contact tracing done here.
All my answers are going to be on big picture.
Yeah. Okay.
Because that would match anything I'd say about Texas anyhow.
Okay.
So, yeah.
Big picture.
So I will say up here in Massachusetts that we were very fortunate that there was a widespread, aggressive contact tracing program, neighborhood by neighborhood. They could tell you which communities had what positivity rate, and then they allocated resources to those communities, specifically the exact communities you would expect to be hit by this the hardest with service workers. So Chelsea, Everett, East Boston, certain parts of Dorchester, Quincy, Mattapan. So these are more densely populated areas. These are areas where people are living, more than 2 people per housing unit, because density isn't as much as important as how many people per household. And but they did put a lot of resources in it. The website is updated daily. I have been quite impressed by the response, both from Boston, the city. I live just north of the city, and also at a state level. I was expecting it, but you have to set your bar low based on what we're seeing. So
True.
I'm happy to report in Massachusetts, it's been very a cohesive process.
Well, as a dad, and you probably don't know this, David, my daughter just started Boston University. She moved in this week, and she's been tested 3 times. She's only been on campus for about 6 days. And, I don't know if it's Boston University or Boston/Massachusetts, and the environment of taking this seriously. I feel so much safer that she picked Boston University over Emory or, whatever. Can you imagine? My mom is up there. She's 75 years old. And they, for most of the summer, they were living in Jacksonville, Florida.
That's rough.
Okay. So on a personal level, I am so happy that they are up there with you.
Right now, I think we're going to see problems down the line because of having one of the highest unemployment rates in the country, but there's also a much more robust set of safety nets, and it's a lot easier to access unemployment benefits. So, we'll see how that impacts things down the line.
I think that's a great question. That raises a great question in my mind, which is because look at the difference between Terry, Karen, and yourself and me on a state-to-state response to this. Which of our state-level economies are going to accelerate towards, a healed state? You know what I mean? Like a normalcy faster. I know there's too many variables to put them side by side because each state has its own industries. But in general, I'm just saying, you know, one of our friends, Mike Kidd, our resident biostatistician, you know, has been monitoring open table reservations as a proxy measure, as a litmus test, you know, and that's how robust is the recovery per state. It's interesting. I think that we need to examine that. We're going to have to look at that, you know, as we move forward. The states that responded robustly, did they recover robustly versus the ones that didn't?
Well, look at New Zealand. You know, they obviously had a very strong response in how they handled that. And being an island nation is a little bit maybe different in terms of how your ability to respond. But their GDP, I think, only dropped maybe 1.6% versus Sweden that did nothing, obviously. Well, I don't want to say nothing, but went with a more lax approach. And I think their GDP dropped by like 8.7% annualized. So.
Right. Yep. And ours dropped by about 10. Is that correct?
I am not as up to that. I hesitate to answer.
Okay, we'll take a look at it.
Waiting room, Sanjay?
What's that?
Waiting room?
Do we have someone in the waiting room?
Yeah, I believe so.
Oh my goodness, I'm sorry. Hang on.
I'm just gonna, while you're doing that, I'm just gonna throw in, because I'm a healthcare organizer, I have a lot of contact with doctors and nurses, and I'm on a lot of policy calls as well too. And I get a lot, I have a lot of friends that are contact tracers, and I get the best stories, man.
Well, I just saw that Katie joined us. That's my neighbor locally here. Again, she missed some of the beginning, so I want to apologize directly to her. Katie, I haven't been able to respond to you. My FB Messenger has been overwhelmed. And the other part is you missed a part about the long haulers and a treatment potentially on the horizon. So I promise you that I will, after this is over, I'll message you. But anyway, so what we'll now, well, let's do line number 3, healthcare access. Have we provided COVID treatment for everyone? And have we passed legislation that would allow for COVID recovery to take place without the additional burden of having to rush back to work? One, potentially going back too early and actually causing further spread. Or 2, you go back and you're physically unable to do the job that you were once able to do. So I had a doctor contact me, and she was told that they do not have enough providers and that she had to come back to work as soon as she tested negative, after suffering about a 4 to 7 day, tested positive, got, felt sick, and then had about a 4 to 7 day rough, experience with COVID. And then during the 3-day recovery process, was offered testing and was told that she needed to get back to work. So she was literally only given 14 days, which may not have been enough for her body to completely clear the virus. So she went back to work treating patients while she may still have been shedding the virus. Of course, she was masked and all that other stuff, so she's protecting her patients. But now that's not just the only story I've heard. But okay, so my rating on healthcare access is a 2 for the country, a 2.
Big picture, 1.
Okay.
So I'm going to go with 0.
Okay.
Because people have lost their jobs and subsequently have lost their healthcare coverage.
Okay.
I'm also going to go with 0 for Wisconsin because we could have expanded Medicaid here, but we did not.
Yeah.
So we have people that are left without coverage, and that's a crime. So I'm going to say 0.
Okay. David, what do you think?
I had jumped ahead earlier and said 0, and it's not because I am fortunate. I have good health care. I hope I don't get it, but if I did, I wouldn't go bankrupt. But I think it's the question of like, what does the word all mean? And when I think about it on a national level, I mean, Massachusetts has a universal health care initiative. It was what the ACA was based upon. So I don't want to be, captured by, I don't want to have the availability heuristic and think that where I live is representative. So I would think that just what I'm hearing from other people, that I don't know if 0 is rational, so I would have to go with 1 just because some people have it. But like, if all is the modifying word, if like that's the operative word, then it would be 0. So I don't know how to really answer that one.
Yeah, I mean, I'm surprised they gave it a 2, but it just seems like we had plenty of people crash into our ERs with no health insurance, and we took care of them. And that's what we do.
So that's very reasonable, right? Like, we have laws that say like we cannot turn you away. Like, if you're crashing, like, we're not going to be like, well, you don't have a card. Like, well, he's unconscious, so we're not going to ask him for his debit card.
Yeah.
So maybe that's where I'm like, all right, I can't go 0. That's not rational. But like, if they become homeless because they have to default on their mortgage,
right?
I
Yes.
mean, then like, when do you draw that cutoff line?
So this is a good point to make. Well, one, I'm going to corroborate Karen's assessment of 0 by saying that all of the undocumented sick, okay, I mean, those here with who are undocumented immigrants who were sick, unless they were at the edge of death, were not adequately given healthcare access. So that's a few 100,000 people in Southern California and Arizona. I would also say that 0 for those who were moderately ill and were afraid to go and seek treatment at all, and could have it ended up, with complications thereafter. They just didn't go get treated because they didn't have insurance for whatever reason. So even though they tested positive, a COVID positive test should have been a somewhat of a ticket for treatment, an adequate containment, but it wasn't. So that's where I think Karen's assessment of 0 is accurate. The only reason I gave it a 2 is because we did save hundreds of thousands of people who came crashing into our ERs. So, like you said, David,
I'll just say a little bit behind my 0 is also that I know even if you do have insurance through your job, there's a high percentage of people that will delay care because they're worried about their high deductibles. A lot of people have a $5,000 or $6,000 deductible, and when you only make $20,000, $30,000, $40,000 a year, it can take you quite a long time to save up $5,000 or $6,000.
Yeah.
So I know that a lot of people delay care or deny care, even though they have insurance as well. So not only do we have people that have no insurance, we have people that are denying themselves care.
Correct. So the fourth line here is data and analytics. I have to say that our ability to assess daily trends and then also recommend adjustments to our strategy based on those daily trends was awful. So as a healthcare informatics professional, someone who's been working on this for about 20 years. I would have to give the United States a 1. And the United States was saved only because of private universities who took up the responsibility. I'm speaking directly about Mayo, UC San Francisco, Mass General, and Johns Hopkins. So they were the only ones that were disseminating information that was clinically relevant as and when needed to the 700,000 clinicians on the front line. Okay, so that's a 1 from me. How about you?
If you take away the corona trackers that were out there that were done very well, our government, our healthcare system took those numbers and flushed them down the toilet. Yeah. So I would give them a 0. I could give them a negative because no part about them are realistic. I don't believe any numbers anymore from this country. It might as well be friggin' Russia.
I have to agree. I can't fault you on that assessment. You know, you and I've been struggling with this from week 3. Like,
I think it goes back to the 3rd show where I was like, okay, maybe not.
Right, exactly.
I am going to say a 1, and I'm just going to bring back the memory of the state of Georgia not putting their data in chronological order.
Oh, that was garbage.
Do you guys remember when that happened?
Oh, I have the screenshots from it. Oh, I was going to talk about it. Yep. I don't want to interrupt. I'm sorry, but yeah.
No, absolutely. I love this format. I love when everybody can just kind of, you know.
So I'm gonna go with 1 on data and analytics. David.
Oh, 1. Yeah. So let's say that early on, right? Maybe there was a little bit more independence of the CDC. Let's say that at first it was maybe harder to kind of influence that, right? And there was already the infrastructure just to kind of respond. But at a national level, how do you report it if you can't rely on what the states are reporting? You can only report what states are giving you. And so we know that, at first it was quote unquote only the Democratic states that were, getting hit. And it was only a Democratic, problem. New York and New Jersey and Massachusetts and California and Oregon were getting hit up hard. Were those more reliable? I don't know. But, what you said about Georgia DPH, I mean, they put it out of order. And not just did they put it out of order chronologically, but they changed the order of the counties to make it look like it was going down. And it didn't make any sense at all. And I mean, Brian Kemp apologized, his spokeswoman apologized, the director of the DPH apologized. I mean, it was, and then they did it again.
Yeah.
And so I don't know like how to respond to what has the CDC done, but then they mixed the antibody tests with the nasal tests. So I mean, I can only go 1. I can't go above that. And
yeah, and so you talked about Georgia. Let's not forget, in Florida they fired the woman who was in charge of collating the data. And then in Texas, Mike, again, our guy from the resource page, our friend, I think his hair is falling out at this point because of how like he's trying to make sense of what the reporting is that's happening in Texas.
Did you see the interview with the Florida statistician yesterday?
No, I missed it. I know.
I think she was on CNN yesterday. So look for it. She was brilliant when she was on there.
Yeah, I will check for that. I'll post it, in fact. But so this is pathetic. So we've actually, not us, the United States has actually allowed states to do their own thing. And some states have obfuscated data or have just been completely incompetent in doing this. Now, I have tried, to give benefit of the doubt and be forgiving and give certain explanations about how South Korea, this is their third or fourth round with a pandemic level event, that they actually know what they're doing. They have a pandemic playbook. It's routine for them to just put up, an announcement saying, everybody wear masks. We have a new virus and everybody complies. And all the data collection and all the track and tracing infrastructure is, it works like a Swiss watch, in their country. And in ours, well, Terry would probably describe it best, but it's with some choice words. But this is our first goat rodeo, and it has been a goat rodeo. Okay. Because there was, the states weren't handed a plan or a workbook, for all of their infrastructure and their institutions to fill out and do, so that everybody was doing things at the level of a Massachusetts. Okay.
Well, Sanjay,
yeah,
there was a large playbook which they reduced to a 10-page playbook.
Yes.
Back in the beginning. Mm-hmm. And that's maybe how we ended up as the little kid in the neighborhood who has to wear the helmet and the elbow pads. That's America on the world stage. You know what I mean? It's the truth. We're seen as completely inept.
Yeah, yeah, absolutely. No, I said this from the beginning, that I've been getting calls from Malaysia, India. We have South African friends that are just in shock. Just absolute shock. The most powerful, the wealthiest, the purportedly best healthcare system in the world brought to its knees. And forget about the healthcare system, the governmental infrastructure unable to deal with data and analytics and assessment and recommendations and protocols. I think it was a couple of weeks ago, it struck fear into me thinking about if we ever were victim to a large-scale bioterrorism attack, or if we ever, were to have to deal with something more deadly and more rapidly spreading than COVID. We better have effing learned our lesson with this one. I can't see Brian.
I couldn't deal with this. It's one of the simplest things ever.
Yeah, we couldn't deal with that. Yeah.
A nation, the first class nation in the world, supposedly, can't deal with wearing a mask.
Yep.
We have 100-year history of fighting against masks. It goes back to 1918.
Right.
We had the same thing. No, it was the exact same thing. They had mask deniers 100 years ago.
Just can't fathom it.
So
you would think in 100 years that people would adjust to science and facts.
We're rugged.
Sometimes
it's rugged individualism.
Well, think about this, guys. Sometimes you have to take into account that it was too long ago.
Yeah.
No one remembers. Okay? If it happened 25 years ago, 20 years ago, 15, like it did to South Korea and the rest of Asia, okay, they remember. 100 years ago, nobody remembers. Nobody is alive right now.
They could actively go visit the graves of the people who passed 25 years ago.
Yep. Yes, exactly.
Oh, we have to do the last one, Sanjay.
Yes, last one. Sorry, last one. Totally zero, because so this was an option for other countries to consider, right? They New Zealand primarily, and many other Asian countries shut down their border for 6, 8 weeks, 10 weeks, so that they could control whatever they had within their borders, and then slowly open their borders to both outbound and inbound travel, and then have protocols in place to deal with that, because so we still don't know what strains are prevalent and dominant in the United States. The New Zealanders are testing every new case, also gets a complete gene sequence, a genomic analysis of that viral strain or strains that are present in that patient. So they'll know whether that patient contracted it in Vietnam, Hong Kong, Singapore, South Korea, wherever in the Pacific Rim a particular strain is more prevalent. They can determine where that patient contracted it. Now, we can't do that when we have 40 to 50,000 new cases a day within our own borders. And we've been banned travel basically anywhere else in the world. So the world did half of what we needed to do for us by banning Americans from traveling outside our borders. So thank you to them. And then the other half of it is no one wants to come here because we are the worst hit. So our travel and tourism industry has taken a massive hit. But I don't know if we're doing what we need to do with those people who are coming here. I just don't. So that would be a 0.
I take a trip down memory lane, and I can remember when we shut off travel to China. In the meantime, we had thousands upon thousands of people a day coming in from Europe. And they would get off their plane and run out of the airport, hop in a taxi, and go spreading whatever strain they had.
Straight into downtown Manhattan.
So I would give it a negative if I could. I would give, for this final one, I would give it a negative.
Yeah.
It was like we were begging for it. It was like, please come infect us. We cut off China from coming here. That horse had ran out of the barn, down the street, through the next town. You know, it's just ridiculous.
Yeah, true.
So I'm going to say 0 for this too. My poor niece that lives in Washington State is engaged to a man from Vancouver in Canada, and she cannot see her fiance because Canada won't let her in.
Oh my God.
And she got engaged in this park. It's like the only place that you can go where you can see each other. She got engaged at, it's called Peace Arch Park.
Mm-hmm.
That's where she got engaged. And then she had to go home and he had to go home. So I'm going to say 0 because they're keeping my niece apart from her loved one. But once she does get in Canada, she's getting universal health care, everyone. So
yeah.
There you go.
There's some time limit before you're eligible, I believe.
Oh, really? Is there?
Yeah. And in most countries where they have universal health care, there is a gray area you have to go through before. They just don't hand you a card and say, hey, we'll treat whatever you got.
Yeah. So, and we have our favorite Canadian with us, Giselle's with us. But okay, so now our assessments across the board are around a 1.
It's a big steaming pile. And
now, please understand, we published this 2 months in. 2 months in, this was out there. It was on our YouTube channel. It was on our resource page. We covered it extensively. And now here's our scorecard. At week 24, 6 months later, here's where we are. And this is why we have the highest number of cases and the highest number of deaths.
It's a shit show.
Now, okay, so the last exercise here is what can we do about it? And I'll do it myself here. Basically is going down this list, assessing incidents, well, COVID tests need to be ubiquitous. They're not going to be free. Unless, no, they're just not, right? This is America, let's be honest. They're not going to be free. So we're hoping they'll be around $12 to $18, and you can pick them up at CVS or Walgreens, and they'll be available in the next 6 to 8 weeks everywhere. And we're hoping, right? But even though we won't be doing this on a weekly basis anymore, we will do this once a month. And we'll gather all the data and evidence, and hopefully we'll invite some very, very interesting guests to talk about this stuff. Like we can hopefully get Mike to come in and talk about his biostatistics, and others. But you know, we'll keep pace, and we'll keep tracking, and we'll keep disseminating the information. But we're hoping that by the next time we speak to you in a month, that some form of at-home testing is available and that it's affordable. But I don't have any hopes that it will be free. Serial detection and rapid testing. Like I mentioned, my daughter is at Boston University, proud papa, and she's going to start classes this week, and she's already been tested 3 times. So that means that they are taking it very seriously. That serial detection, testing on demand, when you have kids in close proximity to each other, these aren't kids, they're adults now. But in schools, teachers that need to have it done, healthcare workers. I know a nurse, a close friend of mine, who's been working on the front line for, 5 months, and she's only been tested once. So she could have been one of those asymptomatic carriers, and she could have been spreading to other patients, and no one would know. Okay, because they just weren't available. They were prioritizing this test to be available only to sick people initially, and then healthcare workers were pretty much last in line once the test became more available. Anyway, so that's my assessment on testing. We have failed, and for us to restart our efforts and get out of the pandemic, assessing incidents is going to still be number one in terms of importance. If anybody else has any thoughts on that, please just stop us and jump in. We can probably eliminate contact tracing from our agenda until we have less than 100 cases per state per day. What is that? That's 5,000 cases a day nationally. We currently have 40 to 50,000. Okay, so that you can just leave that off the list for now. Maybe a state like Massachusetts that's been doing it for 4 or 5 months can serve as an example and a template, and then teach the other states to do it well. That would be my hope. That would be the most practical hope that we could have about this item. Okay, healthcare access. Again, we live in the United States, and I could replace that word with we live in the Democratic Republic of Congo, and all of these things would still be valid. I don't know how you feel about that, but I kind of feel pretty miserable. Okay. So, that nation's been ravaged by war for 4 decades, and their president changes every 4 or 5 weeks. So, it's a complete disaster. We could replace it with any number of failed states, and all of these things would still be in the same category as the United States. So are we going to offer treatment for if a patient has COVID for free so we can end this pandemic as soon as possible? It doesn't look like we have the political will to do so. Are we going to offer paid convalescence of at least 6 weeks for anybody that gets COVID? Probably not. Data analytics. Oh, well, maybe once the CDC is back under some semblance of scientific leadership, we, all those people I was talking to you about, my friends and colleagues, will go down to DC and take the reins, and then we can turn this whole thing around. What's Terry?
That's 4 months.
4
4
months.
months
Yes.
before that can happen.
Correct. You're right. Correct.
So we're talking 330, 350 dead.
Yes, that's
Okay.
right. And so, and lastly, halting inbound is also about having the will to shut down again, I would say, to a certain extent. Okay. So we don't have the will to shut down again. It won't happen. So we're going to see it, instead of having addressed this, 5 months ago, 4 months ago, we're going to see this long tail of continued healthcare system at red line, continued excessive, we'll call it excessive death due to COVID, even though we've reduced mortality by about 70%. And the thing that is most concerning is the number of people who will have moderate to severe disease during this period and come away with morbidity and be long haulers or be recovered with sequelae that's going to reduce their quality of life. I'm sorry, I'm not painting a pretty picture, but this is just all science and reality.
I'm amazed that finally now people are talking about the long haulers.
Yeah.
I've been talking about it since the first month we were doing this.
Oh, yeah.
The hidden cost of what this disease is doing to the country.
Yep.
And like you would say, once a person is dead, you don't increase the money thrown at them.
Right.
But if someone is going to be sick for weeks, months, years after they've had this thing, it's going to hit our healthcare system and what we pay for personal insurance like a nuclear weapon.
Yeah, absolutely. Let me reiterate a story that I told. So when I was clinician lead at Geisinger for analytics, we did Geisinger has its own healthcare plan. Okay. And so we were sharing information, anonymized information on patients who were in the plan, but also being treated by a Geisinger primary care physician. And we focused on chronic disease, right? So we wanted to find out what's the cost of care for every person with COPD, okay? COPD has NIA classifications, New York Association, that categorize in severity, all right? So the higher you go in the classification, the more likely you are to have exacerbation, ER visits, all this other stuff that needs to happen. The more severe your cardiovascular disease, coronary artery disease, the more likely you might have a heart attack, you might have a stroke, all of those things. So we came down to this group of patients, small for what we're talking about, but it's a perfect example of what healthcare costs do once the chronic disease crosses over into something more severe. All right, these are in living patients. All right, so kidney disease has 4 stages, stage 1 through 4, and we had about 5,600 patients that were at some stage of kidney disease. So it's a pyramid. So stage 1, larger group, stage 2, smaller, stage 3, and then stage 4 is a small group of people. And out of that small group of people, about 300 a year out of the 5,600 chronic kidney disease patients, about 300 a year, quote unquote, graduate to end stage renal failure, end stage ESRD, end stage renal disease, and they require dialysis, right? So the yearly cost of dialysis for a patient is about $56,000. I think Medicare pays about 62 or 50, well, it depends. But anyway, a guy saying we were more efficient, we were able to do it for a lower cost, and there was bundle payment, and these patients were very expensive to take care of. So when you had about 5,000 patients with chronic kidney disease, it cost the health plan a grand total of about $150,000 to take care of all those patients. That includes all of their twice or three times a year GFRs, which is the glomerular filtration rate renal panel, and 2 visits to their primary care physician and 1 visit to their nephrologist a year for all 5,000 patients to make sure they stay on track and keep their kidneys as healthy as possible and don't let them proceed to the next higher stage of failure. But inevitably, after 5, 6, 7, 8 years of chronic kidney disease, some patients will trip into end stage. So 5,000 patients cost $150,000 a year total. 300 patients, once they hit end stage and needed dialysis, cost $9 million. And so when you have, let's say, 1 million COVID patients, 100,000 to 120,000 patients are going to go through the disease and bring with them some form of sequelae: heart disease, lung disease, renal disease, something. Okay, and let's graduate them as 3 years from now, 5 years from now, 8 years from now, when their kidneys fail. Like Terry was saying, this isn't a short-term cost. This isn't the economy and this in this quarter or this year. This is the cost of their care for the next 8 years or 10 years. It's going to be, for an individual patient, it's going to be in the millions. So we're talking about billions of dollars for these patients. Okay. And so if you're not going to take the pandemic seriously today, the pandemic is going to cost you. It is going to rob you. It will steal from this country for a decade or more. Okay. All right. Well, that ends my presentation.
On that chipper note.
Hey, at least we won't have a payroll tax, right?
Yeah, no. Nor will you have Medicare or Social Security.
Right.
So
Yeah, that's the downside.
We won't have any of these things going forward if there's 4 more years.
So anyone else, any thoughts? Please jump in. We're not even doing a post show. We're just gonna keep this rolling.
So I assume Terry kicked out all of those people that said they were coming. They always show up, so I'm assuming that they all showed up. Everybody had their debates in the first 10 minutes, and it was fiery.
Yeah,
why do they always run from me?
I know, right?
Man,
So
I throw a couple lines down on people, and they run and run and run.
Man, that and wow.
I had the line all ready for the one guy, you know. Well, hold on, Don. There are no kids around, are there, Don?
Yeah, there are.
Oh,
they've
okay.
heard it, Terry.
Oh. Well, I was going to tell the guy from Canada that, you know, the student organizer is not what you call the guy who leads the circle jerk. So.
Yeah, but we have proved this over and over and over. We've proved it over and over again. Open invitations, personal invitations. Come and say out loud what you think, you know, this is all about. And I'm just going to sit here and give you my perspective that's evidence-based. That's it. That's all you have to do. I'm not going to humiliate you. I'm not going to berate you. I'm not going to call you names, because I will do that on a post. I will do that on a thread, okay? But if you come here in this public forum where I have to behave like a professional and I'm on video, not that what I say on a thread can't be shared and damage my reputation. I know that, okay? If I use language, quote unquote, unbecoming of a physician on Facebook, that can be used against me, sure. But here, I promised anyone who showed up, they would be treated, their ideas would be treated respectfully.
I didn't.
I know you did. Yeah.
Terry made no such promise. Awesome.
Well, we'll let Sanjay keep his name, and then I'll enter someone's nightmares. I don't care.
You'll be the stuff of their nightmares for months to come.
I really am enjoying recently, well, not recently, like it seems to have gotten to a new level recently where when you ask anyone for any kind of a shred of evidence to support what they've posted or what their claim is,
nope.
It's like you're a criminal. You should just be sent to federal prison for 5 years for asking that.
Nope.
It's baffling.
Someone told me that I should do the research for myself, and I said
all the time.
And I'm like, well, why don't you do the research first, or just take your head out your ass? You know.
They seem to know what it is, so explain it.
So after months of calling bluffs and after months and months of so it's now they're predictable, right? So that the CDC announced the 6% nonsense.
Oh.
You know, every single one of your conservative friends is going to have that plastered on their wall the next morning. Every single one of them.
So now it's the 3%ers, which is this fringe militia group, and they're also posting 6%. So they're all over numbers.
Yeah, yeah. Why is that so predictable? Because I mean, we told them, look, we know this. It's called confirmation bias. The first shred of evidence that comes in front of your face that confirms something that you believe to be true, if you latch onto it, all you're doing is internalizing and amplifying this bias.
Yeah.
That's all. And then they have the audacity to tell Terry. They told Terry to learn to be a critical thinker. So I mean,
awesome.
So, come on, man. Oh my God.
I was like, oh, okay. I'll get right to work on that.
They mean you need to critically think like them. You know, they don't mean to go out and learn it. They want you to think exactly like they do.
So is someone checking the chat log for anything of interest to
I have a question.
Yes, Lorene, please go ahead.
Yeah. I'm just wondering if there's anything new on the vaccine.
No, they're all in phase 3 clinical trials. So the most this has been a very, very aggressive program of vaccine development, no matter who you speak to. What we talked about platforms, right? So you know the different platforms. The one that's being spearheaded, pioneered in the United States is the mRNA platform. The one in the UK by Oxford AstraZeneca is the attenuated chimpanzee adenovirus platform. So the last I heard, and again, you won't see data on a day-to-day basis because these are patients like, I think the N of patients here is somewhere between 3 and 10,000. I mean, this is a very big, significant pool of patients here in the US. And then in the UK, it's 30,000. After those 30,000 go through about a 3-month evaluation, an extensive 3-month evaluation, they will then ask for about 1,000 of them to undergo what's known as a challenge trial. So they will voluntarily be infected. Okay. So they've been immunized by the platform, by the vaccine, and then they will, the vaccine's efficacy will be quote unquote challenged by giving these vaccinated people an exposure to COVID. Okay. So again, it will be, I don't know what the actual material and methods will be for it. but it's probably going to be some sort of aerosolized, nebulized viral vector that they all receive the exact same dose. So they all have the exact same inoculum of virus, and to see what percentage of them get symptoms and what percentage of them will display immunity. And then moves forward to phase 4. And phase 4 is in market. So in market means,
We're going to skip all that.
Oh,
I'm not kidding. I'm
That's
not
what I'm
kidding.
hearing. Yeah,
It's coming
Lorene,
for the
go
election.
ahead. Sorry.
that's what I'm hearing, that they're going to skip this, so it comes out before the election. But the only problem is that it's going to probably be 2 doses with like 3 weeks or 4 weeks in between.
Yep.
So that's gonna screw it up for a lot of people.
And it has to be kept at a very low temperature. Good luck with
Yes.
that.
Oh, I didn't. Yeah. Some
Mine
vaccines
was
do. Oh,
0.
mRNA vaccine definitely does. It is heat labile. I forgot about that.
Yeah.
Yes, it is.
So
The other vaccines are much more tolerant, heat tolerant.
Hey, I have a quick question about strains.
Yeah.
So I thought from the very in one of the beginning shows we did that I remembered this, but now I'm not sure. So are there more strains because we let it run across the population so widely? Does that contribute to having so many strains?
Yes, absolutely.
All right.
Yes, absolutely. So the larger the population and the longer the duration of the pandemic, and longer population affected and longer duration of the pandemic, the greater number of strains eventuate. Absolutely.
Okay. All right.
No,
then we could recap and say that you can catch another strain, even if you've already had a different one, and convalescent plasma is not going to work on a different strain. Ta-da!
Yeah, exactly. Terry pointed that out last week as one of the problems as well. So convalescent plasma will not address regional differences in strains and things like that. So you have to be much, much more meticulous about collection and dispensing. It has to be regional specific, strain specific for maximum effectiveness. David asks, is it necessary to do a challenge trial from an ethical and clinical standpoint? Well, ethically, we don't have a control group and a test group. So it's not like these patients who are being challenged, half of them are being told that, half of them are just receiving water vapor, and then the other half are receiving water vapor with the virus in it to control. No, we don't do that. And also, taking one step back is that you don't you don't inoculate anyone that hasn't had the vaccine, right? So there's no control group of people who have not been vaccinated that you're giving them COVID, because that would be severely unethical and clinically, dangerous. So we just do it. They're volunteer. Out of the 30,000 that received the clinical trial phase 3, you ask them to raise their hand and say, yes, for the good of humanity, I will undergo this challenge trial. And they come forward. And so there may be selection bias, and it's always the younger, stronger people who come forward and all that stuff. But what they'll do from that group that comes forward is try to pick out a demographically representative group of 1,000 people, right? So it's not all 6'2", 200-pound Marine Corps guys that all get the challenge. They all get through it, no problem. It will be a group of younger, a group of middle-aged, a group of 50-year-olds or whatever, half women, half men. They all get the challenge, but they will have to volunteer. Yes.
I guess what I mean is that is in any vaccine development, is that a prerequisite? Is that a necessary step? Not that it is not, it offers obviously a significant amount of utility when you can control the inoculum and the strain, because you get a very much more, there's less variation in the results, but is it necessary? And I'm sure that this is an area of reasonable debate that maybe, your answer might be maybe, but I mean, is it standard for new vaccines, whether it's for an existing disease, for a novel disease? Is it standard? Is it necessary before we would open that gateway of let's open it for manufacture? Because I have a huge concern as someone who has who has spent a considerable amount of time advocating for vaccination. It's a sincere concern of mine that we will release one to Lorraine's point before it's been demonstrated safe and effective, and would be not even just that it wasn't proven, but that if it isn't, that we will completely eradicate trust in federal agencies more than we have.
Good
so
point.
Is a challenge study the critical control point in that process?
So I'll answer this in two ways. One is for safety and efficacy purposes, I would have to assume and advocate that a challenge trial is necessary. Okay, I don't know if regulatory processes insist upon it. That's my first, kind of professional answer from a clinician and molecular biology perspective. To ensure efficacy and to ensure safety, a challenge trial is scientifically necessary. Okay, that's my answer there. Then on the personal recommendation, or an educated recommendation to everyone in this town hall right now, and speaking directly to what David said, we are unfortunately being given a choice. We're unfortunately being given a choice to take the first vaccine available, and that vaccine may be the result of political pressure to issue a vaccine as soon as possible. And that vaccine may not have undergone all of the safety and efficacy tests necessary. Or we can choose to wait until all the checkboxes are checked from a more diligent, scientifically rigorous producer of vaccine. So I hope that helped to answer that.
I think when it comes to
it does actually.
I'm sorry.
I was saying it does actually, because I guess the key phrase that I didn't ask, but that you answered, that clarified for me, is you said, as a clinician, I would want to see a challenge study. And so I think that was an important turn of phrase that you used, that you were saying as a professional before, I would recommend that I would want to see XYZ steps. Mm-hmm. So that, I think, answered probably my question, maybe more than you knew, regardless if maybe that is the federal mandate to go through that process. So that right there, saying as a clinician, I would want to see that before saying, one, yeah, you should get it because we know it works, but two, we know it works and you can go on with your normal life. And I'm, as someone worried about, as someone worried about a risk to the community, yes, you can go see your grandmother now that you're vaccinated.
Right. Correct. Yes. So associated with that would be caveats around any vaccination mandate. So if the government came forward and said, we're mandating every child to receive this vaccine on this platform before they're allowed to return to school next September 2021, okay? That would be highly questionable, both clinically and ethically. Do you see where I'm going with that? So
Absolutely.
without a challenge trial, without safety and efficacy data, for the government to go forward with a mandate would put me out on the street with Karen with the protest signs. So definitely, both as as a parent, but also as a healthcare professional, and I wish I was like Natasha and all our other friends on the group page, in the front line of immunology and working on a wet bench like I used to. And especially in this era when they have all those cool tools like we didn't have when I was doing it. But yeah, I've been there, done that, seen it. Part of the fight against HIV starting in 1993 was when I was a research assistant at the Hospital of the University of Pennsylvania. So I'm steeped in this stuff. I'm imbued by it, by this this rigor, the scientific rigor that goes from zero all the way through all the clinical phase steps to market introduction to the first 1,000, 10,000, 100,000 patients that receive this, whether it's a therapeutic or a vaccine. And then, seeing that done successfully is a mark of pride and honor for the healthcare community. But we've done it wrong before, and we've hurt people. And if we do this now in the midst of this heightened what would you call it? Heightened
level of scrutiny.
Well, scrutiny, and also people's distrust for our methods and the entire scientific community becoming under a cloud of distrust or mistrust, whatever it may be. It will scar our efforts for generations, at least one generation. So we can't rush it. Is the short way of saying everything I just said. We can't rush it, and and we cannot. There will be very, very strong objections, even from within our community, to say to object to any government mandate of if you can't mandate masks, how are you gonna effing mandate a vaccine, right? So.
Did you want to hear what the upside is? There's a new burrito special at the CDC. You get that and a large Coke for $5.99.
A side of rice.
You heard it here first.
Okay.
I heard you can get a Labradoodle there too.
A Labradoodle, maybe.
Well, he's a breeder. He's a breeder. Yeah.
There's a Labradoodle breeder running the show there.
Yeah.
Gotta love it.
So I'm just trying to scroll back through the comments to see.
I was going to say,
you guys
Don,
have me covered, right? I haven't missed anything.
I was going to say, Don has been with us a few weeks now and hasn't said a thing. I think it's time for him to unmic and say hello.
Yes.
Someone did ask about your snoring dogs.
Okay. Yes, that's Lily.
Oh, yeah. The mic's off.
Hi, Don.
Hello.
Hey, Don.
Good to see you. Where are you from, Don?
Virgins, Vermont. Bernie territory.
Ah, awesome. Excellent.
Yeah.
Yeah. I think I had a thread, post, chat, whatever, with someone from Vermont recently, and it looks like even better than Massachusetts. You guys have controlled any outbreak or any issues with COVID from pretty much the outset, right? Even when the Northeast was undergoing a outbreak. So did you say near Burlington?
Just below Burlington, yes.
Okay. Awesome.
We're worried about the reopening of secondary school, primary, of elementary and secondary schools and colleges. Middlebury, UVM, St. Michael's are all back. And the news is that the Middlebury College students are not abiding by the stay on campus rule, and they're not abiding by the mask rule, and so there's a lot of fear.
Sure.
There was also earlier some concern that the Department of Health, the Vermont State Department of Health, was somewhat cooking the numbers in that they weren't quite counting one test, they were only counting the other test. And you guys know more about that stuff, a lot more than I do. I raised the question publicly in alternative news, and they may have started counting the right numbers now. But we are in general pretty good. We're a very rural state.
Yes. Yeah. I would say that, you know, the checklist of things, those 5 things that we talked about and gave our national grade, I think that you can use that at a microcosm level too. So if you have a college and a community of maybe 1,000 or 3,000 students, I don't know how big these schools are, but this extends all the way out to about 10,000 students, or community that surrounds them of about 10 to 15,000, even that. If you can create a bubble within that community and address all of those 5 things, okay, so no one inbound to the community without adequate testing, without all of that stuff. That's hard, right? Within the community, everybody gets serial testing, rapid results. If anybody tests positive, there's a contact tracing and a isolation of positives. And then there's isolation to healthcare delivery, right? Where there's no admixture of anyone from outside of that community, right? That hospital serves that 10 or 15,000 people. So if you go back through that slide that we all gave grades on, you know, those 5 things, you can apply that to a microcosm. And those still apply and are still highly effective. You know, testing, tracing, healthcare access and delivery, so nobody stays home sick, or nobody, you know, is in a restaurant serving those kids who's undocumented, who doesn't have health insurance, who's afraid to get care if they get sick, who can't miss work if they get sick, because that's going to happen. There are workers that are in dire straits, and they need that community of students, and they are at risk from and risk to that community of students. So all of those things, if a community around a school or a small town in a rural area can abide by all of those recommendations, you can end the pandemic locally for yourself. So
I'll use that, Sanjay. And I've been arguing pretty much that for quite some time now locally. Middlebury College is wealthy enough and small enough, and Addison County surrounding it is small enough,
sure,
that could be done. Burlington is going to be totally out of control.
Sure. Yeah, absolutely. And you know, a huge amount of students and a lot of variability and influx, and you know, agreed, totally understand.
Thank you. I sent you an email, and I heard you open up by saying, I can't respond to them all.
Yeah.
Our concerns here, Willard's and Alice's and Liana's and mine, are much more personal than you folks are addressing. You're way more global than we are. We're down at the level of, you know, should we disinfect our bare feet after we take a walk down the road in a Vermont urban setting,
Right.
that kind of thing. So
Sure.
anyhow, I look forward to your podcasts. I will miss this group.
Well, this group will most likely stick together. We just won't be meeting every week. I'm pretty confident that, in fact, with less frequency, we might see people being able to join, you know, and with regularity. And I'm very confident. This group is amazing, great people, and we'll do our utmost to continue to be here for you. And like you said, one of the things that we tried to do is allow a personal approach to us, you know, to me, you know, if you have questions like that. Initially, I was responding to everybody, and I know there were a lot of questions. There's still a lot of questions. What you just reminded me, and I failed to tell people about, is yes, these questions are very important. Can you walk barefoot, and do you have to do this or that when you're coming home from a specific location, like a grocery store or a friend's house? Or what do you have to do if you're visiting someone who's 65 and older and you haven't been tested in the last 2 weeks? You know, we've tried to cover that on a week-to-week basis. One of the things that came across recently was a lot of people have been coming out of their stores or coming out of workplaces, in fact, and they hang their mask on the rear view mirror. So why do we not want people to do that? Well, one of the reasons is, especially in the summertime, and now it's going to be the opposite when we go into the fall and winter, is that this surface on the outside is capturing particles and vapor, okay, from the environment you just walked around in. If you then put that on your rear view mirror and your air conditioning or your heat turns on, all of that is just going into your car, into an enclosed space. So you're just blowing around everything that was just captured on that mask, okay? And it's getting recirculated inside of your car. That's, you know, greatly increasing your risk of contamination and infection. So what we recommended very early on from our first video where Terry and I put our skull gaiters on is that whenever you get into your car, whatever has been exposed and contaminated, put it as down low as possible into the footwells of your vehicle or into the side pocket of your door, okay? And then immediately wash that. If you're using the same net gaiter for the same activity over and over throughout the week, that's highly contaminated. It's not even worth putting it back up on your face if you've used it over and over and over without washing it. And so the higher up in your vehicle you hang that thing, it's just going to be blown around, and all those particles are going to be, you know, right into your nose and face.
Sanjay, I saw someone say that you should think of your mask as like a pair of underwear.
Yeah, it is.
So that kind of retrained me. Like, would I just throw my underwear on my kitchen table when I got home? I don't think I would do that.
Yeah, I mean, fresh out of the wash, right? You can take your underwear and go, oh, it smells nice and fresh, right? And at the end of the day, you wouldn't want to do that, right? You just don't. Oh, look, does it still smell good? No, just don't do that. So it's a great analogy, right? It's a great analogy.
I have this habit of when I get home from work, because I've worked all throughout this thing, and the first thing I do is I'd come home and I would spray my boots. Mm-hmm. Because I'm in contact with a large number of people. The second thing I would do would be to strip down and put all my clothes, mask, whatever, in the dirty clothes.
Yep.
Then I hop right into the shower.
Yes.
And it's a hot shower. And I try not to, you know, walk around and pollute my environment in between. And I've been doing this since March.
Absolutely. That's a great habit. So once you've developed that habit, which we all should have developed by now, as soon as you come home, you hand wash. As soon as you are out of an environment that may have contaminated your protective gear, which you you put it away from you. Okay, don't hang it in front of your rear view mirror now. You know, just it makes sense, right? Take that stuff and keep it away from you because it is contaminated. And then the other aspects of that we've learned that we were ultra cautious about in the beginning was disinfection of surfaces and things like that. We've learned that that's probably the least likely route. Surfaces, unless it is, you know, directly contaminated. This surface is directly contaminated by particulate expectorant from other people that you don't, you know, in public. Then that surface, if you touch it and then touch your face, it is a route. Okay, but if you are in your car, or, you know, grocery bags brush up against your car seat and they were in that environment, can that car seat now be considered contaminated? Not as likely, not as a primary or highly risky route of infection.
So a hypothetical question. Say I'm a guy who lives in Texas and I work with a lot of stupid people.
Okay. All right. Hypothetically. All right.
Hypothetically, would it be wise to go that extra mile?
Yes.
Okay. See, there's that.
Yeah, I mean,
thanks. It's hypothetical.
Yeah. The rural Vermont, this gentleman's going out barefoot walking in a clean environment with very low incidence and prevalence of COVID infection. I mean, to stay vigilant is good. It's important, but to be overly, overly cautious is just exhausting after a while. So as the risk comes down, your vigilance can come down with it, but not, not insensibly. So the more we learn, the more we can apply that learning to tailoring our habits to our own level of comfort and safety. So, Terry works with hundreds of people. They all have different hygiene habits, and, it's an environment where it's highly possible to contaminate surfaces, sneezing, whatever. Yeah, then he has every reason to be extra vigilant. But Don up in Vermont, it'll just be exhausting after a while.
My wife and kids want to talk more with you about that. I'm a zero tolerance kind of guy. And so we're pretty strict and disciplined.
There's nothing wrong.
We don't eat cream cheese without heating it to 170 for 5 minutes.
Okay. All right. Well, yeah. So,
but I really would love to hear from you in some way, and I have been mining your resource page.
Mm-hmm.
I would really love to hear that I'm being entirely too hard-assed about this. And yeah.
Yes, you are. Yes.
Well,
Okay.
I would ask Don, what's the positivity rate where you're at?
I mean, if it's below 1%,
yeah.
If it's below 1%, Don, then you guys are at the tail end of your risk level. Okay. As long as you stay vigilant with certain basic habits, and your percent positivity rate is below 1% locally, you're coming to the end of the impact of pandemic on your life and your community. Okay, so we're recommending anybody with lower than 5% can go back to school with cautions, and those who are between 5 and 9%, which represents most of the country right now, even then they need to keep up with all of the vigilance that we've suggested. Mask wearing is a must. Hand washing is a must. Minimization of exposure to other people is a must. Can't be, within 6 feet of another person, even if you're masked for a long duration of time. All of those things. But if you're below 1% in your local, context, then I recommend keeping habits, but I don't recommend the heightened vigilance of someone like Terry living in Texas, or Karen living in Wisconsin, that's struggling now between 5 and 9%. Terry is dealing with a community with greater than 10%. I think they're at 16% positivity.
It's come down, but numbers.
Yeah, exactly. You don't really know. You can't rely on those. But I mean, if the true numbers aren't your death rate, are not your daily. It's really your percentage positivity for the last 7 days. Out of 100,000 people or out of 1,000 people, how many tested positive? If that's below 1%, then your community is now descending down to a risk level of where your basic habits are going to keep you safe and not heightened vigilance.
But we should say, given how many virus deniers we're seeing, that we admire your intent to protect your family.
Yes, very much so.
So well. So I'm just going to say hat tip to you, sir.
Yes.
And your wife did not send us any kind of check or monetary incentive.
Yeah.
Thank you, Karen. As a matter of fact, my wife and I are Contra dance organizers for the Queen City Contras in Burlington. And I think we're the first dance series in the Northeast to close down. We saw it coming, and I pulled my kids out of school. Mm-hmm. I mean, one of them was homeschooled already, but the other was in elementary school. I said, "You're not going anymore."
Yeah.
Period. You're out.
Yeah.
And just a few days later, they shut it down. So yeah, we're okay. But thank you, thank you. I will try to ease up.
Okay. Good. I wish that everybody was as vigilant and took it as seriously throughout the country as you have done. If that were the case, then this would have been over a long time ago. There's no other route of transmission here. Okay, this is a aerosolized virus, and if your level of vigilance was practiced throughout the country, this would have been over a long time ago. Over, like New Zealand level over, even in a country of 330 million people, it would have been over. So I'm with Karen in commending you. All right, any other questions? Where are we? What time is it? Oh my God, it's 10 o'clock. There we go, 10 o'clock. Anyone sad? I am not.
I'm hungry.
Okay. All right.
It's been a good run. We'll
great.
just come back monthly and something else, and we'll get the podcast going.
Yes, absolutely. And we will alert you on when our first version is going to be available. Our topics are going to be, obviously news-based. We're going to have a section where Terry and I discuss, either the comment of the week or something like that off of Facebook, because that's going to be great. Look at Karen; she's already laughing. We haven't even done one yet. And so I've got a list of segment ideas that I'm going to talk to Terry about, and we'll get this thing rolling. But it will really extend out from where we've been now. Terry and I are commentators on this pandemic experience, but we've been commentators on the socio-political experience for more than a decade on Facebook. So we're going to merge those two and talk about society, policy and politics, and healthcare. And I hope.
And even odd topics we come across.
Exactly. Yep.
All right. I have an important update on that.
You do?
Yes. I learned last night that my dog, Joey, can eat whipped cream faster than a can of whipped cream can spray.
I saw that.
You should talk about that. That's a medical mystery.
I salute you, Joey.
But does Joey eat the cheese distribution from the cheese spread container?
So, we're a strictly a sheet-based cheese product family. The only cheese products we get are the sheet-based ones. But
Sajid?
every
Oh,
once
I'm
in a
sorry.
while, I'll let my dogs cheat. You know, we get them like the fish skins and sweet potatoes and things like that. But I had some raspberry pie over the weekend for my birthday. Yay! And so I'm putting whipped cream on it, and my dog's just dying. And I'm like, you know what? All right, whatever, guy. And I go to like, haha, you're gonna love this, right? And he's eating it faster than it's coming out, and I had to try it again. It's amazing. It's incredible. Whereas my other dog, like, she thought I attacked her.
Did
All
you see
right.
that,
So talk about that on your podcast. That's a
we
topic.
will. 2019 iPad. Did you see who that is?
Oh, I don't know who it is.
Madeline?
Is it Madeline?
Is that Madeline there?
Yes, there she is. How are you, Madeline?
I am well. How are you, Sanjay?
Good. Great to see you.
Oh, good to
Were
be
you
here.
able to catch the part we covered on Bradykinin?
Yes, actually,
Okay.
I read the article today. It was in
Good.
my mailbox. Yeah.
Cool.
Yeah.
Excellent.
Yeah, you know, in the very beginning, I thought this was a mast cell activated disease.
Yeah, I know that. You were right. Madeline has been our molecular biology whisperer. From
Yeah.
Yeah.
We really do have the smartest people.
We do.
Yeah.
We do.
Besides excluding me, you're all really smart.
That's not true.
And every once in a while, a blind.
Would not be as awesome without all of you. So I love you guys. Stay healthy, stay safe. We will keep you abreast of everything that we're going to put out there. Okay.
Excellent.
All right. Have a good
That's great. Thank you very much, guys.
You're welcome.
Bye.
Good night.
Good night. Good night. Bye.
Good night. Good night.